Hello, everyone. And the next section is about the CDO intervention part 1. So joining us here is I'm Dr. Ngô from Vietnam, and this is Michael Nguyen from Australia, and then Alan Chan from Hong Kong, and Takuma from Japan. And next to me is Dr. Binay from Nepal, and Dr. Hoàng Văn from the north of the country, Vietnam. So the first speaker today is Dr. Anfazia Omar from Malaysia, will give us about the evidence-based CTO PCI. How do I select my patients and prepare for my procedures? Please.
Thank you. Good afternoon. So my talk today is about evidence-based CTO PCI. How do I select my patients and prepare for my procedure? So I think it's going to go an overview of some of the evidence briefly on this CTO PCI, which some of us are very passionate about. So I think chronic total occlusions are, of course, clinically and technically challenging. However, the good news is that the success rates have improved. So the progress in CTO PCI, we have this advance in many tools and also imaging devices to assist us in how to achieve better results. There are many novels and dedicated tools for CTOs. And I think there's also many centers or many conferences like this, like we can share cases, improve our knowledge, and also more and more dedicated CTO PCI centers. So various clinical presentations of patients, how do you select your patients? I think most importantly is those who are symptomatic. So when they have stable angina, they come and present you in your clinic and you have chest discomfort, you do a stress echo, you do a MRI or a cardiac CT and you find to have occlusion or total occlusion. Some of them you'll find in ACS when you do a PCI, they have got a culprit vessel, but they also have another CTO lesions. And there are some who are asymptomatic. So this is one that we need to be a bit more circumspect and look at the evidence. Incidental findings from ECGs, incidental findings from CT coronaries or nuclear tests. So this is where we need how to approach our CTO, because when we are young, you want to do all the complex PCI, and when you get older, we want to do more simple, more DCB, keep it easy, nothing left behind. So CTOs, we know, are associated with angina, but also with dyspnea and fatigue. And sometimes they are inappropriately labeled as asymptomatic, okay? So, and what happens is that when it's simple to do, okay, we'll do it, and if it's too complex, we say, okay, medical treatment, so it becomes a bit biased. So CTO, of course, have poor prognosis, double jeopardy with higher mortality. You have higher arrhythmias burden, poor tolerance for future AMIs and other ischemic burden index. So we know for sure that, and we've seen in our practice, so we don't, I mean, like in DCB as well, we've seen in our practice that those who have angina, who have got chronic total occlusion, and when you do a successful PCI CTO, they get better, they feel better. And that's the whole point of treating patients. You want to make sure that they have improved in either their angina limitation or their quality of life. And many papers have shown that they have improvements in the quality of life and in their angina symptoms, in their stress tests, their physical limitation. So, in your practice, when you see a CTO detected, then you really have to check whether they have symptoms of shortness of breath, you have angina, you do your health status. I'm not sure how many of us actually do a questionnaire on quality of life when they come into your clinic with CTO lesions. So if you have angina, then it's quite easy. And then you have normal wall motion or hypokinesia in the CTO territory, then you will go towards revascularization. Because sometimes most of us will see a CTO immediately to revascularization, but you need to go through these steps. If they are akinesia or dyskinesia, then you need to show how much significant ischemia and also viability. And I'll show that the next slide. If they are not viable or they know ischemia, then you go for optimal medical therapy. If they don't have symptoms, then you look at their LV function. So no symptoms, patients say it's incidental findings of the findings. If they have normal LV function, you can go for optimal medical therapy. However, definitely if you see a CTO in a prox LED, big vessel, then you really have to evaluate closely and carefully, because usually there will be some form of ischemia that you can highlight. If there is no angina but there's LV dysfunction, again, you need to show significant ischemia and viability, and if there is, then you might want to consider for revascularization. So, when you see a CTO, is it an isolated CTO? Is it a multi-vessel or in previous bypass? I think there's a talk later. Is it Rostam? I'm talking about bypass PCI CTO. So isolated CTO, not non-LAD CTO, you go for CTO PCI if they have angina or they have high ischemic burden. If you have LAD CTO, I mean heart team evaluation, but if it's, to be honest, if it's isolated LAD CTO, most of us will go for a PCI CTO. However, it's still important, like your structural heart, you need to go for your heart team evaluation. And what do you evaluate? You evaluate the patient. So you evaluate for frailty, you check for the lesion complexity, the surgical risks, and all that. So this is very important for the patient to evaluate. So CTO in the context of multi-vessel disease or in CTO in previous bypass. Then you will consider whether you go for CTO PCI, you go for hybrid revascularization, or you go for bypass, so on. So how do we evaluate for myocardial ischemia and viability? So in echocardiogram, stress-induced wall motion abnormality in 3 out of 17 segments are inducible ischemia. You can check also for myocardial viability as well, same. Then other parameters like MRI, again, stress-induced ischemia in 3 out of 16 segments, or stress-induced perfusion defect in 2 out of 17 segments. And then you can also do to check for whether they are viable, whether they are hibernating. So all of these are important because CTO PCI does carry a slightly higher risk, maybe a risk, increased risk by about 2 to 3% for complications, bleeding, and also so forth. You can also do a SPECT or PET scan and a CT FFR if you have such device. Okay. So when you see a CTO and in a patient who has CTO who requires for intervention, then you need to look at you need to quantify or how difficult. And one of the scoring that we use is the JCTO. So whether you look whether it's tapered or blunt, whether there's calcification, whether it's tortuous, and also the length and the reattempt. So you have a point where 0 is easy, intermediate is 1, difficult is 2 or more. And what we know from here is that if you look at the JCTO score, you can see that the success, guide wire success, and the timing. So you can evaluate the patient, you can evaluate the lesion, and when you have the scoring, you kind of know how difficult is it going to be. So the time that's going to take to cross be more than 90 minutes and all that. The higher the JCTO score that you have, then the more advanced your CTO will be. That means you have less anterograde wire escalation, and you're going towards more alternate therapy like retrograde and ADR and so forth. So AWE, as the higher your JCTO scores, your AW success comes down, maybe, and you need to learn other techniques to improve your success. So you have ADR, you have retrograde. So all of this will hopefully improve your CTO success to about 80 to 90 over percent. So CTO PCI, when you have a patient that comes to your clinic, number one, you have to assess the potential benefit or symptoms. You have to show for any ischemia by some form of stress echo, myocardial imaging, CTO complexity. And then you look at the patient itself and the lesion now. You can look at the JCTO score. You can look at the progress CTO score. And also then you have to have the assessment for the procedural risk, okay, the progress CTO complication score. So all of this you need to go through this exercise before you embark on a CTO because it is quite complex. So the next few slides, just very briefly, how do I prepare for CTO? Okay, number one, as we discussed, patient selection. Number two, prepare the patient. So how do you prepare the patient? Because it might be a long-ish procedure. You might want to have sedation. You might want to put a urinary catheter. You have some form of radiation protection, a red pad. So that's how you prepare the patient and yourself. Number two is prepare the cath lab. And number three, you prepare the operator or operators. So most of us, well, for me, I always like to do with my colleague so that we have two operators because sometimes you need this two-person to bounce ideas. It gets too long. You have somebody there to have a nice discussion. CTO toolbox, microcatheters, wires are too long to discuss here. You will have many different wires, microcatheters, all these devices, and not forgetting complication, you need the coils, you need the covered stand. So all of this you need to be familiar with, and you need to have all these devices, and you need to be updated because there's so many. So every year we see new wires and all this, so and we need to get familiar and to be educated about this device and also different algorithms because there's so many new algorithms about how we approach CTO PCI. So this one is about preparing the operator. So we had to prepare the patient, you prepare the cath lab, and now you prepare the operator. So an operator who sees an angiogram, this is what you will go through your mind. Always, nearly always, you need dual injection and careful analysis of your angiogram. And from here, you will move around this whole thing. Okay, you either go anterograde, you go retrograde, you go anterograde back. So the main thing is that you must be familiar, and you must have the enough device, the skill, to be able to move from one to the other fairly quickly. The problem is if you stay one in too long, you tend to be in this failure mode. You just cause more wire dissection, hematoma, and you just, so you need to be able to, okay, go here, change wire. If doesn't success, go retrograde, change wire. If no success, you might want to knuckle, go down, ADR, because move quickly. So you need to be familiar. So I said this is important. You need to prepare the operator in your mind. This is how you're going to approach your CTO PCI. I've described two very brief cases. I was just thinking which case to show. Both fairly simple, well, not simple PCI, but symptomatic young patients. 28 years old. She was in another center. She had ACS. Actually, she was lipoprotein A positive, so she's got some genetic issue with her cholesterol, and hence, anyway, she had a stent in the mid RCA last year. They attempted for her PCI to the right, distal right, but failed. But she had got more and more chest discomfort. So 2 weeks chest pain, backache, shortness of breath. So young patient. MRI showed ischemia in the inferior lateral. So she's got symptoms. We have produced, because she's so young, right? So we just showed that she's got ischemia as well. So symptomatic angina confirmed with MRI. So this was her angiogram. She's got a mid-stent. Distal was a CTO. So dual injection. Have a look at this. So we went anterograde, but we're prepared to go retrograde. So this is where the algorithm goes into your mind. Look at the septal branches, whether you want to go retro, and all of the other devices that you want. So for her, I think it was a Sion Black. It's just a wire anterograde going all the way down. And she really got better. And we just discharged back to her primary cardiologist, and she's been doing well. Another guy, 45 years old, had a bypass 2 years ago. And it's like a diabetic. And 2 years after bypass at this young age, he comes back with angina. And he has got a Lima to LAD, graft to the D1, graft to the OM, graft to the RPD. RPD was occluded already. CTO right. And so he had a distal RCA stenosis. Lima to LAD is patent with collateral to the distal PD. And the graph is okay. So, but if you look at this, he's got the graph to the OM1. So we were trying to think, where is his culprit? Whether is it the distal right, but the right is supplied by the LAD, Lima to LAD. He's also got a very large OM2 or distal circ, huge distal circ here. So we actually opened up his native LCX and that itself was enough for his symptoms. So I did not do his distal right because it's been perfused by the Lima to LAD. But just by opening his massive LCX, he got much better. Because I think the circumflex and the right is occluded. So this itself was enough for his angina relief for him. So I think when you approach CTO PCI, number one, we all know it's technically challenging. Very important how we select our patients. Number two, you have to prepare your patients for the CTO because it might be 1, 2, 3 hours. You need to prepare your cath labs by all the devices, whether it's the new tools, guide wires, or when you have complications. So you need to learn how to snare, you need how to coiling and covered stands. The third one is prepare the operator. So you need to look at the algorithms, how you approach your CTO PCI. And you have to remember that the CTO PCI, the benefit is for freedom of angina and improvement in your quality of life. Okay, thank you very much.
Thank you very much, Wazir. We're actually running very late because of the previous session.